very good afternoon to everyone. Good afternoon. Right. So everybody is excited, and so am I. And yes, we are here to start with gynecology lectures from today. And I'm going to start with very, very basic things. And these basic things are required to go on to clinical application, right? Which is what we're going to learn today. So we've been constantly talking about that the new type of exams or MCQs are based on integration and concept application, and that is what is going to be my prime, goal today. That I'm going to start from scratch, so that when you do obstetrics later as well, you are clear about whatever you need to know about other things as well. So, right, so we are going to start now, and as I said, yes, I'm going to try and give out my best. Okay, that's something I absolutely aspire for, because I feel that I've been given an opportunity to connect with all of you, and an opportunity to open new horizons for you. And I feel that each one of us, when we are given this kind of an opportunity, we should make the best out of it. So I'm going to try my best. And the first thing that came to my mind today when I got up in the morning was, God, you've given me a day. Let me make it the best I can for people who are associated with me. And that's what I'm going to completely try and do. And this is my little request to all of you as well. Okay, that whenever you get up in the morning, the first thing that you have to ask or say is thank you, that you are being given another day. And the next thing is that you're going to ask God to give you that courage that you need, right, to make that most out of that day that has been given to you. So we are going to try that out today. And as I said, I'm going to start from basics. I'm going to start very soon. And you can see on your screens, we are going to start from relevant anatomy and embryology. This is super, super important, to understand the diseases or the pathologies of gynecology and obstetrics. So this is what we are going to start from. Okay, and I would want you people to, follow a few things. Use the chat box to the minimum, okay? Use it when you really want to ask your doubts. After every topic, I will have a doubt solving session as well, so don't worry about that. I have various ways of reinforcing the same topic with you again and again, so give me that opportunity to reinforce it for you, okay? The second thing that I want to say is you're going to make a good set of handwritten notes, and later on show me, your good set of handwritten notes as well. So make your notes really, really nice. I'm going to highlight at a lot of places that this is important or this is an MCQ. For you people, you have to understand whenever you hear the word this is important, okay, a small Q mark should go there, which means it is a very, very probable MCQ. It may be asked in different formats, but yes, it is an important MCQ. So that's what I want you to follow as well. So make good notes, use the hints that I'm giving you in the notes. The class will have everything, okay, that you need for any kind of exam. So whether you're talking about your professional exams, or you're talking about your AIIMS, or JIPMER, or PGI, or any other exam that you think of, UPSC, or NEET. So I'm not here to teach you for an exam. I'm here to teach you obstetrics and gynecology, and I will do my best, so that you people find it easy to appear for this subject in your exam. So that is going to be, my goal today. And I know there are a lot of people who don't like gynecology, right? I know a lot of people do not like gynecology, so that's probably a problem here, right? But as I said, we will ensure that we make the most out of it. I will ensure that if not convert it into love for gynecology, but at least make the subject simple for you, so that you can revise it multiple times and you can use it for any kind of exams that you need to go in for. Okay, are you all ready then finally? Yes? Okay. You want me to zoom my face. Okay, I'll try it a little. Fine. So we're going to start off today. And as I said, I'm going to start with relevant anatomy and embryology. Okay. So the first thing that we are going to talk about today is what are the structures that we are going to talk about, so that, you know, we know things about them later. So when we talk about obstetrics or we talk about gynecology, you know, we have only few limited structures to talk about. So we have to talk about internal genitalia. We would be talking about external genitalia. Okay, and we would be talking about gonads, right? So these are the basic structures that we are going to talk about, right? Now, when we talk about internal genitalia, what is included in it? So uterus, cervix. Now, cervix is very much a part of the uterus. I have just written it separately so that I'm able to give you certain points that you need to know about it. Okay, so uterus, cervix, fallopian tubes, okay, vagina, right? So uterus, cervix, fallopian tubes, vagina, they are going to come under the category of internal genitalia. In the external genitalia, we are going to talk about a few things that you should know about clitoris, okay, labia minora, labia majora. What is the meaning of the term vestibule, and a few of the glands, okay? And gonads, when we talk about, we are going to talk about ovary, right? So this is precisely what we are going to talk about, right? And we are going to talk about these structures one by one. This part of the class is very, very important. It comes under applied anatomy, and applied anatomy is super important when you talk about surgical branches. So if you are in a surgical branch like gynecology, surgery, right, orthopedics, you have to definitely know about applied anatomy and embryology, because anything abnormal happening there would convert into pathologies, okay? Now, so we're going to first talk about internal genitalia. Okay, that's what I'm going to first talk about. And now I want to know from you, the internal genitalia that we have labeled above, right, are derived from which embryological structure? Can you all tell me? They are derived from which embryological structure? So the female internal genitalia, okay, are primarily derived from the structure which is called as paramesonephric ducts. Okay, they are derived from a structure which is called as paramesonephric ducts, and the other name for paramesonephric ducts is going to be Mullerian ducts, right? So the other name is Mullerian ducts. Now, if the female internal genitalia, so we are talking about female internal genitalia, come from paramesonephric ducts, what about male internal genitalia? What about male internal genitalia? Okay, so the male internal genitalia are going to be derived from a structure which is called as mesonephric duct. Okay, and the other name for mesonephric duct is the Wolffian duct. Okay, it is the Wolffian duct, right? Now, one thing which comes out here, and you have to learn the art of remembering things easily. There is a word that is written here, para. Okay, paramesonephric duct. So just by looking at this word, can you tell me the anatomical relationship between these two structures? Can you tell me the anatomical relationship? It's very easy. When you say Mullerian duct is paramesonephric, it means in the body, Mullerian ducts are going to be located laterally. Laterally to what structure? They are going to be located lateral to the Wolffian ducts. Yes? So, paramesonephric ducts are located lateral to the mesonephric ducts or Wolffian ducts. Okay? Now, we already know what are the female internal genitalia. Yes? What is the female internal genitalia? What are the male internal genitalia? So, very important for exams as well. You should know what all structures come under male internal genitalia. Okay? So, we are going to remember them with a mnemonic, which is called as SEED. Okay? We are going to remember them by a mnemonic which is called as SEED. So S here stands for the seminal vesicles. Okay, so S stands for seminal vesicles. E, ejaculatory ducts. Okay, another E, epididymis, and another D is ductus deferens or the vas deferens, right? So the male internal genitalia come from the Wolffian ducts, which are described by SEED. Okay, the seminal vesicles, the ejaculatory ducts, the epididymis, and the ductus deferens. Very important. Otherwise, you do it wrong in the exams. Prostate is not an internal genitalia. A lot of you would do this mistake. Prostate comes in the category of external genitalia. It is not internal genitalia. So remember it with the term SEED. Okay. Now, something which is very important that you have to know, that this concept of male and female comes a little later in the embryologic life. Okay. Initially, when there is a conceptus, I hope you all know that it is undifferentiated. Yes. So initially, when there is fertilization, a conceptus is formed, it is undifferentiated for quite some time. This differentiating into male and female happens a little later in life, which means if it is an early conceptus, should it have both the ducts or only one of the ducts? Tell me. If it is an early embryo, should it have both the ducts or should it have only one of the ducts? So yes, it has to have both the ducts. This embryo may convert into a male or may convert into a female, right? So early embryo will have both the ducts. Okay? We are keeping all possibilities there. It can be a male baby, it can be a female baby. So it will have both, right? It will have both the Mullerian ducts or the paramesonephric ducts and the mesonephric ducts. Yes? So now we're going to look at what we have done so far, and we will understand how is it going to eventually convert into male or female. Okay? Now, so, if I can say that at around 6 weeks, both the ducts can be seen in the early embryo, right? So both the ducts can be seen in the early embryo, right? So by 6 weeks, you can see a mesonephric duct and you can also see a paramesonephric duct. Now, let us see the same thing in a picture. All right. So we are going to look at this and try and understand how is this conversion going to happen. Okay, so now in this structure, there is a pink duct, and pink is a very female color. So I'm putting it as the female duct. or the Mullerian duct, right? So pink is the female duct or the Mullerian duct or the paramesonephric duct. The blue, you can remember, is a male color. So we are labeling it as the male duct or the mesonephric duct or the Wolffian duct. And as you can see here, there are two Mullerian ducts, so one on each side, and there are two Wolffian ducts, again one on each side. And at least in some part of the picture, you can see that the Mullerian ducts are lateral to the Wolffian ducts. Yes, so the Mullerian ducts to begin with are lateral to the Wolffian ducts. And as I said, in early conceptus, both the ducts are going to be present. Okay, both the ducts are going to be present. Now, suppose this baby is going to convert into a male baby. Okay, so suppose this baby is going to convert into a male baby, right? And when I say that, the male baby is going to release the male hormones. Yes, it is going to release the male hormones. And the two most important male hormones that we are going to talk about here are these two. So they are again in your picture. So one is called as MIS and the other is androgen. And which androgen are we talking about here? We are going to talk about testosterone, right? So we are talking about testosterone. So the male baby is going to release two very important hormones, MIS and testosterone. So what is the full form of MIS? So MIS stands for Mullerian inhibiting substance, right? So MIS stands for Mullerian inhibiting substance. Now, very easy, you know, the short form or when you expanded it itself tells you what is it going to do. Yes. So Mullerian inhibiting substance, once released, is going to inhibit the Mullerian ducts. As simple as that. Right? So it is going to inhibit the Mullerian ducts. The testosterone, once released, is going to do what? Testosterone is going to act on the Wolffian ducts. Okay, it is going to act on the Wolffian ducts and it will convert the Wolffian ducts into male internal genitalia. So I repeat, the male baby will release two very important male hormones, the Mullerian inhibiting substance and the testosterone. The MIS will inhibit the Mullerian ducts, so the Mullerian ducts will eventually disappear, right? The testosterone, on the other hand, is going to act on the Wolffian ducts. And as a result of this, the Wolffian ducts will convert into male internal genitalia. So that's how the male structures are going to be formed inside or in the internal genitalia category. Now coming to very important points. I hope you remember when I said important point, it means the MCQ. MCQ for all of you, okay? So now let's talk about more details about this very basic thing which is going to be asked to you in the exams. The first question. Mullerian inhibiting substance, I said, is released by the male baby. But where is it released from? So it is going to be released from testes, right? But this is again a very broad thing. What part of the testes is going to release the MIS? So it's very simple. The MIS in the end, okay, the MIS in the end is going, it has a word what? S. Okay, it has a word S. So S stands for Sertoli cells. So it is released by the Sertoli cells. Okay. The next question that you have to know. At what POG will this baby start producing MIS? So it starts producing MIS by 7 weeks of intrauterine life. Okay, so by 7 weeks of intrauterine life, there is going to be release of MIS from the Sertoli cells. Okay, and it is going to do what? It is going to cause disappearance of the Mullerian ducts. Now, I want you to ask another MCQ. Okay, which is there any other function of MIS? Is there any other function of MIS? So when you talk about MIS, apart from causing disappearance of the Mullerian ducts, MIS is going to do what? The second very important function, so the first I said is it will cause disappearance of Mullerian ducts. Yes? The second very important function, okay, the second very important function is it is going to be responsible for abdominal phase. Listen to me very carefully. Abdominal phase of testicular descent. Okay. You have to know that the testicular descent has two phases. Okay. There is an abdominal phase of testicular descent and there is a scrotal phase of testicular descent. So the abdominal phase of testicular descent is done by MIS. Okay, what does the scrotal phase of the descent? We will talk about it in a moment. So these are very important things that you should know about MIS. Okay, now what is the other hormone that the testes is going to release? The male baby has a testes. The other hormone the testes is going to release is testosterone. You all know that, right? So it is going to release testosterone. Now you're going to tell me what cells in the testes are going to release testosterone? So they are the Leydig cells. Okay, they're going to be the Leydig cells, right? So testes has Sertoli cells, it has Leydig cells. The Sertoli cells are producing MIS, the Leydig cells are producing the testosterone. Okay, important MCQ number 2. At what POG would the testes start producing testosterone? So this happens by 8 weeks of intrauterine life. Okay, this happens by 8 weeks of intrauterine life. Second, what is the testosterone going to do? So we've already discussed, it will convert Wolffian ducts into male internal genitalia. Okay, so the first function is it is going to convert Wolffian ducts into male internal genitalia. And the second important function of testosterone at this time is what? It is causing the scrotal phase of testicular descent. So the abdominal phase of testicular descent is done by MIS, whereas the scrotal phase of testicular descent is going to be done by the testosterone, right? So these are important things that you should know. Why do the Wolffian ducts convert into male internal genitalia and how do they convert into male internal genitalia? Now, I'm going to show you the second part of this diagram and you are going to pick up what is happening in that diagram. So let's see that diagram now. Okay, so now that diagram that we are seeing here has only the pink ducts. Okay, there is no blue ducts. What does this mean? So when you see only the pink ducts, it means the blue ducts have disappeared. Yes, the blue duct has disappeared. And as you can obviously see, the pink duct, which is the Mullerian duct, the blue was Wolffian. The pink duct is persisting, right? So the pink duct is persisting. The blue duct has disappeared. Now I want to hear from you. Let's see who can give me the correct answer and tell me why have the blue ducts disappeared? Quickly, let's see who is the first one to answer. Why has the Wolffian duct disappeared? Anybody? Why has the Wolffian duct disappeared? Because there is no testosterone now. So no androgens, and therefore the Wolffian duct cannot mature, right? So the Wolffian duct cannot mature and the Wolffian duct is going to disappear. Whereas the pink duct or the Mullerian duct is persisting because there is no MIS. So there is nothing to inhibit the Mullerian duct and the Mullerian duct grows. And then we say the structures convert into female internal genitalia. So very, very important. So highlight of this event, question, very important. Do we need the female hormones? Okay, I am asking you. Do we need the female hormones for developing internal genitalia into female-like structures? Is there any need of estrogen to form a uterus or to form fallopian tubes or to form, the vagina? The answer is no. So please remember, okay? Please remember, every baby or a conceptus, it means will have a natural tendency to convert into a male or a female. Batao? The natural tendency is to convert into a female. And for this conversion, estrogen is not required. Please listen to me very carefully. There is no need of estrogen to form a uterus or to form fallopian tubes or to form a vagina. Okay, what estrogen will do, we will talk about it later. As of now, you have to know that the only thing required to form female internal genitalia is simply absence of male hormones. Okay? So if the male hormones are absent, right, the baby will automatically convert into a female. The male structures will only be formed when the male hormones are exposed in the embryonic life, right? The second important thing that you have to pick up from the diagram, okay? Do you realize that there were two Mullerian ducts? Yes, there were two Mullerian ducts initially. But do you realize that eventually only one uterus has formed? Only one vagina has formed? Yes? Can you all appreciate this? So there were two Mullerian ducts, but only one uterus, one cervix, and one vagina. This is normal development. So how will this happen? This will happen when the two ducts will fuse. Okay? So the two ducts will fuse eventually to form the internal genitalia for the female. So now look at the top diagram once again. I'm focusing it for you, right? The Mullerian ducts which were initially present laterally, right? So the Mullerian ducts which were initially present laterally are crossing the midline, right? So they are crossing the Wolffian ducts to meet in the midline. Yes? So the two Mullerian ducts are crossing the Wolffian ducts and they are going to meet in the midline to form the female internal genitalia, right? Now, remember this thing which is very, very important. Mullerian ducts as well as Wolffian ducts. Okay, so Mullerian ducts as well as Wolffian ducts, I said will appear in the fetus. Who's going to remember and recall and tell me what was the POG when they appear in the intrauterine life, bache? 6 weeks. Yes, I just told you a little while ago, these ducts are going to appear at 6 weeks in the conceptus. By 9 weeks, one of the duct will disappear. and the other will remain. Okay, so very good recall everyone. I'm glad कि आप ध्यान से सुन रहे हो, right? Very good बच्चे, right? So by 6 weeks they appear. By 9 weeks one of them will disappear, and by 10 weeks MCQ. Okay, so by 10 weeks they will form the internal genitalia, which means I can ask this MCQ in various formats. Okay, the first format: when would the two Mullerian ducts fuse to form the female internal genitalia? So the fusion will be complete by 10 weeks. Okay, bache? The fusion will be complete by 10 weeks to form the female internal genitalia. Second, the second format in which we will ask you the same MCQ. When do internal genitalia, when can they be differentiated into male and female? What would be the answer to this question? So if we typically ask you, when can internal genitalia be differentiated into male and female? The answer will be 10 weeks. So if I repeat very quickly, in the early embryonic life, which is 6 weeks, both the ducts are going to be present in the fetus, the Mullerian ducts and the Wolffian ducts. By 9 weeks, one of the ducts will disappear. So depending on whether the baby is male or female, based on the gonad, right, one duct will disappear. If there are no male hormones, the Wolffian duct will disappear. Whereas if the male hormones are present, the Mullerian ducts will disappear, right? And the Mullerian ducts, which are 2 in number, will fuse, okay? They will fuse to form a uterus, a cervix, and a vagina. Yes? Now, look at the picture of the pink ducts again very carefully. In the picture, we can see one uterus, one cervix, one vagina. Yes? But how many fallopian tubes? MCQ हुआ है, बिल्कुल MCQ हुआ है. गायनी में तो ये बहुत बार होगा और क्या होना है, right? So tell me, how many fallopian tubes do you see? 2 fallopian tubes. Okay? So one on the left side and one on the right side. All right? So one on the left and one on the right. Okay. Now tell me, how come 2 fallopian tubes when the other structure is 1? There is 1 uterus, 1 cervix, 1 vagina. Why only we have 2 fallopian tubes? This means that the upper part of the, okay, the upper part of Mullerian ducts remains what? Unfused, right? It means the upper part of the Mullerian ducts is going to remain unfused. Now, MCQ. How will this question be asked to you in the exams? Let me see how many of you are brighter people who can twist things and put them into application. Suppose you go for the exams and we ask you, you all know that the 2 ducts are going to fuse to form the female internal genitalia. I am going to ask you, what do you think, bache, is going to be the direction of this fusion? Okay, what is going to be, beta, the direction of this fusion? Let's see who can tell me. Will you say cranial to caudal? Okay, I'm asking you, is it cranial to caudal or is it caudal to cranial? What do you think is the answer? If we have to mark one answer, what do you think it is going to be? Is it caudal to cranial or is it cranial to caudal? Very good. So almost all of you are bright people. So you're all able to answer it correctly, right? So it has to be from caudal to cranial. So fusion begins from below and proceeds upwards. Yes, so it begins from below and proceeds upwards. Okay, in case we ask you the question, the answer is caudal to cranial. So the cranial part of the Mullerian duct remains unfused and it will form the fallopian tubes. Fair enough. Now, there is another something which is very interesting And this thing that we are talking about, caudal to cranial, abhi yaad rakhoge, because I am going to soon tell you the application of this concept. Okay, we will soon see the application of this one-liner that you're learning. See, application kis cheez se banta hai? When you combine a lot of one-liners, they are going to ask you this. Okay, and we will see the application in a moment. But there is another very interesting thing in the picture of the female internal genitalia. If you see the uterus here, right, have we shown it to you like a solid organ or an organ with a cavity? What do you see here? Is it a solid organ or an organ with a cavity? So the interesting thing that you can see here is that as of now, we have made uterus a solid organ. Okay, I haven't shown any cavity here, which means when the uterus is formed initially, there is no cavity in it. Okay, there is no cavity. Cavity formation in the uterus will happen later. Okay, cavity formation will happen later. The cavity formation happens at 20 weeks. Okay, so by 20 weeks, the range is 18 to 20. The single best answer is 18 to 20 weeks. So the cavity formation in the uterus, in the cervix, in the vagina will happen later. Okay, it will happen at 18 to 20 weeks. Okay, so this is uterus, cervix, and vagina. This is when the cavity formation will happen, and it will happen by dissolution of the solid structure inside. So the solid structure inside is going to dissolve to form the cavity. Okay. Now again, very important MCQ. This dissolution of the connective tissue. Okay. So dissolution of tissue to form a cavity. Okay, so this dissolution of tissue to form a cavity will also happen in a direction of caudal to cranial. Very important. We will learn the application in a moment. Okay, so in a moment, we will talk about this application as well. So dissolution will happen again from caudal to cranial. So these are two very important MCQs. Okay, the ducts will fuse from caudal to cranial, and the dissolution of the tissue will also happen from caudal to cranial. Right? We will see the application of this in a moment. Okay. Now, this is something that I have told you, that in early embryonic life, there are going to be both the ducts and then one duct will disappear. How do we know that this happens like this? For example, we were all not there, when the earth was formed and there were dinosaurs. But yet we say that there were dinosaurs. Yes? So how do you know that in very old earth, when it was formed, there were dinosaurs? How do you know? Tell me. Right? Tell me. How do you know the dinosaurs were there? So it is because the dinosaurs left behind fossils, right? They left behind fossils. We saw those fossils and then we knew that they existed. Similarly, what evidence do we have that although a female is a female now, but she did have Mullerian ducts or Wolffian ducts? So Mullerian ducts, because the structures can be seen. We are seeing the uterus, the cervix, the vagina. But what evidence do we have that the Wolffian ducts were also present? Right? So let's look at this. Very good. You're bright people. So we're going to look at the next diagram now. So we know that women did have the blue ducts because we are able to see remnants of Wolffian ducts. Okay, we are going to see remnants of Wolffian duct in the females. Okay, now quickly, this is again MCQ, very important for your exams. What are these remnants that we will see when we talk about remnants of the Wolffian duct? So look at the blue things that you see here. So the one blue thing that you see here is called as epuphoron. Yes, it is the epuphoron. The another blue structure that you see here is paruphoron. Okay, it is the paruphoron. And we have yet another blue structures which is called as Gartner's duct. Here we are showing you the cystic form of it. We'll talk about it a little later. So which means the three remnants of the Wolffian duct that you should know exist are, so what are the remnants of Wolffian duct? They are epuphoron, paruphoron, and Gartner's duct. Okay, so epuphoron, paruphoron, and Gartner's duct. Okay, very important. So these are the three remnants that we should know. So epuphoron, paruphoron, and Gartner's duct. Now, let us look at the corresponding part in the male as well. Okay, we will look at the corresponding part in the male. Okay, let's look at this. Now, if you see the mesonephric duct here, it has these structures. Okay, these structures that you see in the mesonephric duct are called as mesonephric tubules. Okay, they are mesonephric tubules. And then, you know, these tubules are going to collect or join with each other and they form the mesonephric duct, right? So the tubules are going to join and they are going to form the mesonephric duct. Okay, so epuphoron, paruphoron, and Gartner's duct. We will see from what part exactly are they going to come. Okay, so now if you look at these pictures, can you tell me epuphoron comes from the mesonephric duct, or a better answer is mesonephric tubules? Tell me, what is the better answer? Is it the mesonephric duct or is it the mesonephric tubules? It is going to be from the mesonephric tubules. Okay, it is going to be from the mesonephric tubules, right? Same holds true for paruphoron. So both epuphoron and paruphoron come from the mesonephric tubules. Perfect. ये बहुत ज़रूरी है. Otherwise, you will get confused in two options. You know, a lot of times students say that they get confused in two options always. So, you know, people who have superficial knowledge are able to rule out two options. But when the options get close, that's where they start doing the MCQs wrong. So the first rule to, you know, help you in this aspect is increase the depth of your knowledge. When you improve the knowledge depth, you know, this confusion keeps decreasing. So now remember that the epuphoron and the paruphoron come from the tubules, whereas the Gartner's duct comes from the mesonephric duct. Okay, the Gartner's duct is going to come from the mesonephric duct. Okay, now listen to me very carefully. Sometimes, usually the Gartner's duct will be here. I will draw it blue. Sometimes the Gartner's duct may be present throughout its length. Okay, and you know, the distal end of it gets blocked. It has an opening. So sometimes when it is present in its entirety, okay, yes, Farhan, mesonephric duct is Wolffian duct. Okay, so sometimes the opening of the Gartner's duct can get blocked. Okay, when the vaginal epithelium proliferates, the duct opening gets blocked. What will happen if the opening gets blocked? It will develop collections inside, and then it will form a Gartner's duct cyst. So now we are first going to talk about the clinical relevance of knowing these structures. Okay, so the clinical relevance of knowing these structures is that these remnants, okay, sometimes in adult life can present as cysts. Okay, so Gartner's duct can present as Gartner's duct cyst. Similarly, the epophoron and parophoron can present as what? So the epophoron and parophoron, both of them can present as paratubal cyst. So paratubal means around the tubes, right? So they can present as paratubal cyst. Okay, so the remnants in the adult life can present as cystic growths. So the Gartner's duct will form a Gartner's duct cyst, whereas the epophoron and parophoron can form paratubal cyst. All right. Now, we will talk about male as well in a moment. Hold on. Coming to more things that you should know about epophoron, parophoron, and Gartner's duct. Now, where are these structures located? What is the location of these structures in the female? Okay, so you have to answer, it is like this. Okay, the answer is that these structures are present in an area which is called as broad ligament. I will tell you in a moment what broad ligament is. As of now, I just want you to write where are epophoron, parophoron, and Gartner's duct present. They will be present in an area which is called as broad ligament. Okay, they are contents of broad ligament. Okay, they are contents of broad ligament. What is broad ligament? Hold on, I will explain it to you very clearly in some time. But as of now, just write down that they are contents of broad ligament. Okay. So paratubal cyst will also be present in the broad ligament. But as I said, the Gartner's duct sometimes can be present along its entire length. Okay, so Gartner's duct can sometimes be present along its entire length, and then it opens in the vagina. Which means, where will you see the Gartner's duct cyst? The Gartner's duct cyst is seen in the vagina. So it is seen in the lateral wall of vagina. Okay, it is seen in the lateral wall of vagina. So epophoron, parophoron, and Gartner's duct, they're all present in the broad ligament. Sometimes they may form cystic structures which are called as paratubal cysts. Second, I said the Gartner's duct sometimes may be present in its entire length. And when it is present in its entire length, it opens in vagina. If the opening gets blocked, it will form a Gartner's duct cyst. So this cyst is seen in the lateral wall of vagina. MCQ. Very important, and I will convert it into an application MCQ in some time. As I said, most often the students will get confused in two options. So here particularly they will ask you, which part of the lateral wall of vagina? Is it anterolateral part or is it posterolateral part? So this is very important. This is going to be seen in the posterolateral wall of vagina, right? So it will be seen in the posterolateral wall of vagina. These cysts are seen later in life and they may not be seen in everyone. Only in some people they may form cystic structures later in life, not at birth beta. Okay, so they are seen in the posterolateral wall of vagina. All right. So now we will let you know why you have to know that the Gartner's duct cyst is going to be present in the posterolateral wall, because it is very, very important clinically to differentiate it. Sorry, please, for Gartner's duct cyst, write it in the anterolateral wall. I'm sorry, I wrote it by mistake as postero. Write it as anterolateral wall. Okay, so Gartner's duct cyst is seen in the anterolateral wall. I wanted to differentiate it with something which is seen in posterolateral, so I wrote posterolateral, but we will talk about it later. बेटा पैराट्यूबल बहुत आसान है. पैराट्यूबल का मतलब अराउंड द ट्यूब और सिस्ट मतलब एक सिस्टिक स्ट्रक्चर. So these remnants will form or can sometimes form cystic structures around the fallopian tube. So you will see them as paratubal cysts. Okay, you will see them as paratubal cysts. Okay, so these are some of the very important things that you should know about epophuron, parophuron, and Gartner's duct. Right? So they are remnants of Wolffian duct. Okay, and they are seen in the broad ligament. They can sometimes form paratubal cysts and the Gartner's duct cyst in the anterolateral wall of vagina. Right? Now, once we know this, coming to the male counterpart as well. Right? Which was the duct which is going to disappear in the males? Mullerian duct. So Mullerian duct is going to disappear in males. And will it leave behind a remnant? Yes. This remnant is called as appendix of testes. Okay? So this is called as appendix of testes, right? So very, very important. Appendix of testes is a Mullerian duct remnant or a paramesonephric duct remnant. What is the other name for appendix of testes? It is also called as hydatid of Morgagni. Okay, very important. It is also called as hydatid of Morgagni. Okay, so please remember, we will that they will ask you hydatid of Morgagni. Okay, hydatid of Morgagni is a remnant of which duct? What would be the answer? Wolffian duct or Mullerian duct? Mullerian duct, right? So hydatid of Morgagni is a remnant of Mullerian duct, and it is the other name for appendix of testes. Now, sometimes the words are similar and they confuse you. So males have another structure which is called as appendix of epididymis. Okay, so males have another structure which is called as appendix of epididymis. Okay, and appendix of epididymis is derived from Wolffian duct. So do not confuse this in the exam. If they ask you appendix of testes, it is Mullerian duct. Okay. If they ask you appendix of epididymis, it is going to be Wolffian duct. So don't get confused between the two, right? Is it very clear to all of you? So you have to know what are the remnants of Wolffian ducts, what are the remnants of Mullerian ducts, right? And the different names that we have told you so far. So now you know what is the normal development, how the uterus and the internal genitalia are going to be formed. Okay, yes, Gartner's duct is also a remnant in the broad ligament. Only sometimes it is present along its entire length, only sometimes. When it is along its entire length, then it opens in the vagina, and then its vaginal opening can be blocked. It can then form the Gartner's duct cyst. All right, perfect. Now once you know this, okay, to help you in quick recall, I want you to see some question and I will see who is going to answer this for me. Okay, so we are going to do in its question and we will see who can answer. So a young patient delivers a male infant at term. The baby has normal appearing external genitalia. The scrotum is empty. No testes are palpable in the inguinal canal. The 6th month, the testes have still not descended. And the ultrasound shows that they are in the pelvis. And there is a uterus as well. So these are the keywords for you. Okay, what are the keywords? It is a male baby, right? It's a male baby, but the highlight is that testes is still in the pelvis. It has not descended, and uterus is also present. So what do you think is the pathology here? Tell me. Perfect. सबको आता है. Answer क्या है? Answer is B, right? Lack of MIS. Beta, MIS was the one which was responsible for disappearance of fallopian of Mullerian ducts, right? Now here there is no MIS, and therefore there is no disappearance of Mullerian ducts, and as a result of which the uterus is formed. Okay, so as a result of which the uterus is formed. Also remember, MIS was doing what? MIS was responsible for the abdominal descent. And as you can see here, there is no descent. The testes are still in the pelvis, right? So the answer is B. So do you now understand why knowing the relevant anatomy and embryology is important? Because in your real life, you're going to see these problems. And then on the basis of those problems in the form of patients or newborn babies, you will have to find out what is the pathology. Yes? So the precise answer here is lack of MIS. Is it clear to everyone? Okay, appendix of epididymis is derived from Wolffian duct, and appendix of testes is derived from paramesonephric ducts. Okay, yes, the scrotal phase was by testosterone. तो बेटा उड़ के थोड़ी आ जाएगी, पहले pelvis से abdominal phase of descent तो करना पड़ेगा ना, right? So वहां तक ही नहीं हुआ है, how will it jump into the scrotum? Okay, so the precise answer here is B. All right, so the lack of MIS is the answer here. And yes, we really see patients like this where we have to do these kind of evaluations and we have to figure out what the problem in the baby is. Okay, okay, perfect. So once we have done this problem, now we are going to go on to, once you have done the normal development, I want you to look at what a normal uterus looks like. Okay. Okay, so we are now going to see what is a normal uterus going to look like. So this is once everything has happened, there is fusion, there is cavity formation, right? And as a result of which, this is what the normal uterus is going to look like. So we're going to look at the parts of the uterus. So there is going to be the main part of the uterus is its body. Okay, so the uterine body is also called as corpus, right? So the uterine body is also called as corpus. Then yet another part of the uterus is the cervix. So yes, cervix is very much a part of the uterus. In between the body and the cervix, there is this constriction. Okay, this constricted area is what is called as isthmus. Okay, so isthmus is a narrow, very narrow area between the body and the corpus, or the body and the cervix, right? So it is the isthmus. It's a very narrow area, and between the body and the cervix there is a opening. Okay, so between the body and the cervix there is an opening. This is going to be the internal os. Okay, this is going to be the internal os. Internal os is a sphincter. Okay, so internal os is a sphincter. The smooth muscles, okay, the smooth muscles here are arranged in a concentric manner, right? So internal os is a sphincter. And the smooth muscles here are arranged in a concentric manner. All right. Now, the cervix will open into the vagina, and the opening here is called as an external os. This is also a sphincter, right? So the external opening to the vagina is external os. The internal opening inside the uterus is the internal os. Okay. Then at the top of the uterus, there is the fundus. Okay, so at the top of the body, there is going to be the fundus. So the different parts are fundus, body, isthmus, cervix. Those are the parts of the uterus, right? Okay, now look at this. At the upper end of the uterus, okay, there are two more openings. Okay, at the upper end of the uterus, there are two more openings. Yes, internal os is at the level of the isthmus. That's right. Okay. Now, there are two more openings. These are called as ostia or cornu. These are openings of the fallopian tube. Okay. So, there are two more openings, right? So, there are two more openings. There is ostia or the cornu, one on the right side, one on the left side. These are openings of the fallopian tube. These are also sphincters. Okay, so these are also sphincters, right? Which means that the smooth muscles here are again arranged in a concentric manner, right? So they will open, and close. Okay, then at the upper end of the uterus, if you can see here, at the upper end of the uterus, three structures are attached, right? So at the upper end of the uterus, three structures are attached on either side. Okay, on either side, three structures are attached. These are fallopian tubes, round ligament, and ovarian ligament. Okay, so at the upper end, three structures are attached. Okay, fallopian tube, round ligament, and ovarian ligament. Okay, now these three are together called as utero-ovarian pedicle. Listen to me very carefully, because when we talk about gynecology, core gynecology, we will be using these words. Okay, so utero-ovarian pedicle. Okay, now coming to this, so they are present on either side, right? Before I go and explain you how they are present on either side, when you talk about the uterus or the body, what is it primarily made up of? Now, look at this carefully. The body of the uterus is primarily made up of myometrium, which means uterus is a muscular organ. Okay, so uterus is made up of primarily myometrium, which is smooth muscles. So it is a muscular organ. On the contrary, okay, listen to me very carefully. On the contrary, okay, you have to write everything that I write. Everything that I am writing, you have to write in your own copies as well. All right. The drawings would be there in the files, but everything that I am writing, you have to write as well. Okay. Now, look at the myometrium. What is present on the inside of the myometrium? And what is present on the outside of the myometrium? The inside of the myometrium is endometrium. Okay, endometrium. And the outside of the myometrium is perimetrium. Okay, so I will repeat. Most of the body is made up of myometrium. So uterus is a muscular organ. It is made up of smooth muscles. That's what I said. On the inside of the myometrium, there is going to be endometrium. And on the outer side of the myometrium, there is going to be perimetrium. The endometrium is made up of glands and stroma. Okay, so the endometrium is made up of glands and stroma, whereas the perimetrium is nothing but the serosa or the peritoneal covering, right? So endometrium, glands and stroma, perimetrium is made up of serosa, right? Now, when you talk about glands and stroma are present in the endometrium, what is the lining epithelium? Tell me, anybody? What is the lining epithelium of the uterus? Single layer columnar epithelium. Okay, so it is a single layer columnar epithelium. That's what the endometrium is made up of, and there will be stroma. Okay, now when you talk about the endometrium per se, remember it has further divided into grossly into, you know, two kind of layers. There is a superficial layer to the endometrium. Okay, there is going to be a superficial layer, and there is going to be a deep layer. The superficial layer is called as the functional layer or the functional endometrium, right? Whereas the deep layer is the basalis, right? So the deep layer is the basalis, whereas there is a functional layer as well. What is the clinical relevance of knowing this? We will do the details later, but as of now, the clinical aspect that you have to know is that it is the functional part of the endometrium which is shed off every month. How it is shed off, why it is shed off, we will talk about it when we go on to physiology. Okay, so the functional layer of the endometrium is the one that is shed off, whereas the basal layer is the one that going to do the regeneration. So every month the endometrium is going to be shed off, and every month it will be regenerated as well. Okay, so the functional layer is shed off, whereas the basal layer stays, and it's going to do the regeneration. Application. Let's see who can answer the application now. Can you tell, destroy the basal layer? Let's say I have done a procedure on my patient and I have, done, destroyed the basal layer as well. What will happen? Can you tell me? There will be no regeneration. So then the endometrium will not be able to form again, and the endometrium will now be a raw surface. Yes, it will simply be a raw surface. Okay. So the basalis layer takes part in regeneration. If we destroy it, the regeneration will not happen, right? And yes, there will be no regeneration and it will be a raw surface, right? What do we mean if we destroy it? Suppose we take an instrument inside and I denude the superficial layer as well as the basal layer. So, this is what is called as a curettage. Okay. So when you remove these layers, it's called as a curettage. So if you do extensive curettage, okay, if you do an extensive curettage, you can actually destroy this layer, right? And as a result of which, the uterus or the endometrium is left only with a raw surface. Now I will tell you why is this such a worrisome thing. It's left with a raw surface, but what is the problem? Let's see. Now, To understand the problem, you have to understand another aspect of the uterus. So if I go back to the diagram, we have shown that the uterus has a cavity. Yes. So we have shown that the uterus has a cavity. What you have to know is that although the uterus has a cavity, it is only a potential cavity. Do you understand what is the meaning of a potential cavity? It means this organ, you know, the walls lie opposed to each other. Okay, the walls of the uterus lie opposed to each other, and this is a potential cavity, which means if there is going to be something inside it, then the walls will distend, they will move away. But if there is nothing inside, the walls lie opposed to each other, right? So it is only a potential cavity, and that is why we say, what is the capacity of uterine cavity? Do you know? Only and only 10 ml in the non-distended form. Okay, so only and only 10 ml in the non-distended form. So it's only a potential cavity, right? The walls will move away when you put something inside the cavity. Now, put these two concepts together. Endometrium having a raw area, yes, and these raw surfaces come in contact with each other. Can you tell me what will happen when raw surfaces come in contact with each other? Tell me. So if raw surfaces are going to come in contact with each other, it is going to form what? Adhesions. Yes, fibrosis. So raw surfaces will eventually lead to the formation of adhesions, right? And this is what is called as Asherman's syndrome. Okay, so this is what is called as Asherman's syndrome. Very important for all exams. We will talk more about how it presents, what is the what are the presentations, what is the treatment, how is the uterus going to look in it. We will do it later. But here this has to be remembered as a concept that if you destroy the basales layer of the endometrium, and we know that uterus is a potential cavity, there will be formation of adhesions inside, which is going to lead to Asherman's syndrome. So Asherman's syndrome is nothing but intrauterine adhesions. Okay, so this is different parts of the uterus that you should know. Also talking about the cervix a little here. So I definitely said that cervix is a part of uterus, which is absolutely true. Cervix is a part of uterus, but what you have to know is that cervix is not mainly made up of smooth muscles, which is a contrast to the uterus. Cervix is primarily made up of connective tissue. Okay, only 10 to 15% of the cervix is smooth muscle. Rest all is connective tissue. So it is actually made up of collagen, right? So it is made up of collagen. That's how cervix is very different from uterus, right? This is also the reason why, in pregnancy, you will read in OBS that I have taught you in labor that cervix is able to undergo effacement, yes, which was nothing but thinning. Yes, so we said effacement was thinning and shortening of the cervix, and this change is possible because it is made up of what? Because it is made up of what? Because it is made up of connective tissue, right? So during the process of effacement, there's going to be a breakdown of collagen. Right? There will be a breakdown of the collagen. There will be increase in the amount of water content. So water content will increase, collagen will decrease, right? And there's going to be thinning or softening of the cervix, right? So that is the first different thing that we have to know about the cervix and the uterus. So although the cervix is very much a part of it, okay, it is still, what we are saying is what? It is made in a different way. Also, you have to remember that cervix has a, canal inside. So there is a region of the cervix which is called as endocervix, which is nothing but the cervical canal. Right? We talked about canalization of vagina, cervix, and uterus. So the cervical canal is the area which we call as endocervix. Okay. There is another part of the cervix which is called as ectocervix. Okay. Ecto means because it lies on the outside. Endo because it lies inside. Now, what you have to know is that when you do a per speculum examination, so PS is a per speculum examination, okay? Smooth muscle, 10 to 15% is smooth muscle. Right, so when you do a per speculum examination, what is the part of the cervix that you as a clinician will be able to see? You will be able to see only and only the ectocervix. So you'll see the external os, which is the opening in the vagina, and all around it is the ectocervix, right? So you and me, when we do a per speculum examination, okay, we will only see ectocervix, we will not see the endocervix. Now, the endocervix, please remember, is lined by tall columnar epithelium. Okay, it is lined by tall columnar epithelium, whereas the ectocervix is lined by stratified squamous epithelium. Important, okay, very important. Right? So the inside of the cervix is exposed to or is lined by what? Tall columnar epithelium. Whereas the outside is lined by stratified squamous epithelium. Okay? Which means lies outside, which means in the vagina. Okay? It lies in the vagina. Right? And when you do a per speculum examination, this is the area of the cervix that you can see. You cannot see the entire cervix. You can only see the part which is lying in the vagina. So what lies in the vagina is the opening, which is called as the external os, and around it is the ectocervix. Now, which means the epithelium of the cervix is going to change, right? From columnar to squamous. And there is going to be a junctional area where the two epithelium are going to meet. This is therefore called as SCJ, okay, squamo-columnar junction, right? So it is called as the squamo-columnar junction, also called as transitional zone, right? So squamo-columnar junction or the transitional zone, right? This is where the conversion of tissue is happening from one epithelium to another. So who is going to tell me what is the term in pathology we use when we talk about conversion of epithelium from one form to another? What is the term? This is metaplasia. Okay, this process is called as metaplasia. Right? So when the epithelium changes from one form to another, it is metaplasia. So what you have to remember is metaplasia is physiological at the level of the cervix. Right? So metaplasia is physiological. Right? So this is physiological. Also, because here the cells are converting, this is also the area. So squamo-columnar junction or the transformation zone or the transitional zone right? So we also call it as the transformation zone. This is also the area where most commonly you will see pre-invasive and invasive lesions of cervix. So if malignancy is going to happen in the cervix, it is going to happen most commonly in this area. It can happen in the other areas as well, but most common site for cervical malignancy is this transformation zone or squamocolumnar junction, right? So this is important. We will talk about malignancies later, right? But this is what you need to know when we talk about the squamocolumnar junction. Also, please understand, as far as metaplasia is concerned by itself at the level of the cervix, this metaplasia is not considered as pre-malignant. I told you, metaplasia in cervix is physiological, okay? It is physiological. So if they ask you, is metaplasia in cervix a pre-invasive lesion or a pre-malignant lesion? The answer is no. Okay, this is a physiological process. It's not pre-invasive or pre-malignant. Is it clear to everyone? Okay. Also, when we talk about this, we said the uterus primarily has two parts. Yes, the body, which is the corpus, and the cervix. What you have to know is that when a child is born, right? When the child is born or a girl is born, at that time, the cervix is the major part as compared to the, the body or the corpus, right? So we said at birth, the ratio of corpus to cervix is 1:2. Okay, remember this, right? So at birth, the ratio of corpus to cervix is 1:2. Gradually, as this girl grows up, you will see different changes happening there. So after puberty, okay, immediately after puberty, because of all the hormonal changes happening, this ratio is going to reverse. So now the ratio of corpus to cervix, okay, is going to be 2:1, right? So now the ratio is going to reverse, right? So in the pre-pubertal time, it is 1:2. After puberty, it is 2:1, right? And throughout the reproductive years, right? So throughout the reproductive years, this ratio remains as 3:1. So that's why I initially said that corpus is the main part, because we are talking about the reproductive phase of the female, right? So the ratios keep changing depending on the hormonal effects. So in the pre-pubertal time, right? So before puberty, the ratio is 1:2 of corpus and cervix. After puberty, it becomes reverse, 2:1. And throughout the reproductive life, the corpus to cervix ratio is 3:1. It's just to tell you that there are physiological growth of the uterus is happening, which means if I ask you the size of the uterus of a newborn girl and the size of uterus of an 18-year-old girl, will they be same or different? Tell me. Will they be same or different? They will be different, which means the uterus grows, right? It is going to grow. As compared a newborn girl to an adult female, the uterus is going to grow. Can you tell me, what did I say? It grows under what effects? What effects? I said hormones. Yes, do you remember? I said hormones. Okay, so it grows under the effect of estrogen. Now let's go back to the basics that we did in the anatomy or embryology. Was estrogen required, right? Was estrogen required for formation of the uterus? Yes or no? The answer is no. Uterus is not required for formation of the uterus. Estrogen is not required for the formation of the uterus. But what is estrogen required for? Growth of the uterus at puberty, right? So it is required for growth of the uterus at puberty. Okay, so typically I wanted to tell you pre-puberty and post-puberty, that are the changes. So 1:2 and 2:1. Particularly if we ask you at birth, although these kind of questions are not coming any longer, at birth the ratio will be 1:1. So I just wanted to highlight the changes before and after puberty, and that is why I wrote it as 1:2. Don't bother, as I said, the factual things are not very important now. What you need to know is that there is a growth which is happening, or a differential growth which is happening, which is because of the hormones, right? So now let me see if you can answer this question quickly. If there is absent estrogen, uterus will be present or absent? What would be the answer? If there is no estrogen, uterus will be present or absent? Uterus can be present, because presence or absence of uterus is not dependent on estrogen. But if it is absent, will the uterus be able to grow or not? No, the uterus will not be able to grow, right? Which means the uterus will remain small. So in the absence of estrogen, the uterus will remain small, and we use the term which is called as hypoplastic uterus. Also, because I said it will remain like that in a baby girl, so another term we use is infantile. Super important. When I am going to do disorders of sexual development with you, or topics like primary amenorrhea with you, if you don't know these concepts, those topics are going to be very, very difficult for you. So understand the concepts very clearly. For formation of the uterus, estrogen is not required. But for growth of the uterus into an adult uterus, hormones are required. So in the absence of estrogen, uterus may be present, but it will remain small. So we say hypoplastic or infantile. That was the clinical significance because of which I had to tell you that the uterus grows. Okay. Now, once we know all this, coming to something that I told you, that on the upper end of the uterus, 3 structures are attached. Do you remember the 3 structures? We said the round ligament, right? The fallopian tube and the ovarian ligament. 1:1 is at birth, beta, if you particularly want to know at birth, whereas 1:2 is before puberty. Okay, so before puberty 1:2, at birth 1:1. Okay. Now, when we look at this structure, this is a laparoscopic view. Okay. Before I come to this view, I will show you how a pelvis looks like on laparoscopy. Okay. So we will see what the female pelvis looks like on laparoscopy. So I'm going to play a video for you, which is a laparoscopic view of the female pelvis. So this is a laparoscopic posterior view of the female pelvis, right? And that's how beautiful it looks. You can see a plus sign right now on your screens. This plus sign is moving, which is actually the uterus. Now the plus sign is on the fallopian tube. On the other side, fallopian tube, right? The white structure that you see adjacent to the fallopian tube is the ovary, which means ovary lies posterior to the uterus. Okay, which means ovary lies posterior to the uterus. So the globular structure is the uterus. Now this plus sign is moving on the area there which was the pouch of Douglas, right? And now it is on the bowel loops. So this is how the female pelvis looks like, okay? So you should know what grossly it looks like, right? When you see this, you will now be able to see, you know, what in the picture I am trying to show you, okay? 1:1 was at puberty, beta. Sorry, at birth. 1:1 at birth. Okay, 1:2 before puberty. It is the ratio of cervix to. Okay, since a lot of you are asking this, before I go to the picture again, corpus to cervix birth is 1:1. Okay, before puberty 1:2. Okay, after puberty the ratio reverses, it becomes 2:1, and throughout the reproductive life it is going to be 3:1. So just for people who missed on it, I have written it again. Now I'm going to talk about the structures again. So this is the view that we had seen. Okay, I have labeled it now for you. So as I said, we were seeing the posterior aspect of the uterus, right? So this is the posterior surface of the uterus. Then we saw the fallopian tubes, and I said right adjacent to the fallopian tubes was the white structure, which is the ovary, right? Now there is this structure which is going from the uterus to the anterior abdominal wall. Okay, so anterior abdominal wall, and this structure which goes to the anterior abdominal wall is the round ligament. Okay, it is the round ligament, right? The ligament that attaches the uterus to the ovary is the ovarian ligament, right? So those were the three structures that we had seen: the round ligament, right, the fallopian tube, and the ovarian ligament. Now listen to me very, very carefully. Which is the most superior structure out of these? The most superior structure out of these is the fallopian tube. Okay, the most superior is the fallopian tube. Now below the fallopian tube, okay, you will listen to me carefully. Below the fallopian tube, the round ligament and the ovarian ligament are attached at same level. So they are both below the fallopian tube and they are at the same level. The difference is that the round ligament lies anterior to the fallopian tube and the ovarian ligament lies posterior to the fallopian tube. Okay, so which means in your exams we are very fond of asking you what is the antero-posterior relationship of these structures. So if we talk about the antero-posterior relationship, the answer will be round ligament followed by fallopian tube followed by ovarian ligament. Okay, so the most anterior structure was round ligament, then comes fallopian tube in the middle, and then comes ovarian ligament. Okay, so this is supero-inferior and antero-posterior relationship. Now I want to ask you, why would we want you to know the AP and the supero-inferior relationship? Why would we want you to know this? Because whenever we are going to do a procedure on the fallopian tube, it is very important to identify the correct structure, right? If you do not identify the correct structure, you will do the procedure wrong. For example, there is a procedure which is called as tubal ligation, okay, or female sterilization. Now in tubal ligation, we are going to put the fallope rings, which I will show you, on the fallopian tubes. If I don't know my anatomy well, what will I do? I will put the fallope rings, let's say on the round ligament, and I will tell the patient that I have sterilized her. What will happen? She will come a month later and she will say, doctor, I have missed my periods. I did a pregnancy test at home and it is positive. But then she will say, doctor, you said that you have done a sterilization. How come I am pregnant now? So what will you tell the patient now? So you will tell her, sorry, I put the fallope rings at the wrong place. Okay. So this is a gross error. So please understand, whenever you want to perform a procedure on a structure, the first important thing is to know its relevant anatomy. You know, you people get very angry at us. Why do we ask you relationships? Okay. I know you're weak in all kinds of relationships, whether they're anatomical or other relationships at this age, right? So this is the reason why we ask you relationship, because you will otherwise cause failure of ligation surgery by ligating the wrong structure. And this is one of the very common reasons why the tubal ligation fails. So one of the common reasons why it fails is because you've ligated the wrong structure. All right. Now, let's talk about this picture again. You see another word I have used here. That word is adnexa. So in gynecology, we will be using this word quite a number of times. What is adnexa? The fallopian tubes and the ovaries are together called as adnexa. Okay, so the fallopian tube and the ovary is together called as adnexa. So in gynecology, we're going to very commonly say adnexal mass. So whenever I say adnexal mass, you have to know this mass can arise from the ovary. This mass can arise from the fallopian tube. This mass can also arise from both of them. So it could be a tubo-ovarian mass, or it could be a mass from structures around the fallopian tube. So adnexa is a word which we use very commonly for tubes and ovaries together. Is this clear to everyone? Okay. Now, this is what is the normal development of uterus. Now I'm going to show you another picture. Okay. Now we're going to see another picture and you will tell me what's wrong with that picture. So now we are going to talk about abnormal development. We've talked about normal development. We will talk about abnormal development. Okay. Now, look at this picture here. If you look at the uterus first of all, always and always, I want you to first focus on the external contour of the uterus. So external contour of the uterus is like this. So this is the uterus, this is the cervix, which means the normal external contour has to be convex upwards. Yes, it is convex upwards. Is this right? So whenever you get an image in your exams, the first thing I have to teach you is that you have to look at the external contour. Now, just stop giving me your diagnosis. अगर तुम्हें सब आता होता तो मेरी क्या जरूरत होती है ना? So अभी तुम्हें नहीं आता, अभी मैं सिखाऊंगी. Now tell me, if you look at the external contour of this uterus, is it normal or abnormal? Answer only the question that I'm asking you. Is the external contour normal or abnormal? So look at the external contour. It is very much normal. Yes, the external contour is normal. Okay, now look at another uterus and tell me. Now there is another uterus on your screens. Normal or abnormal? Normal external contour. Okay, now be careful. Look at the uterus on your screen now. What is the external contour? What is the external contour? So this is abnormal external contour. You are seeing a dip in the external contour at the level of the fundus. So when we say external contour, it means we are looking at the fundus of the uterus. Yes, so we are looking at the fundus of the uterus. So the first thing, beta G, when you will go for your exams, you have to look at this as the first thing. Is the fundus, bache, looking normal or it is not normal? Now, once you have identified this, we will try and pick up the problem. If the external contour is normal, or in other words, the fundus is normal, but what is the problem here? I am seeing two cavities. So the external fundus is normal, but there are two cavities. Yes, so external contour normal, but two cavities is what is called as a septate uterus. Who is going to recall what I told you? Do you remember that I said canalization happens later by dissolution of the material inside? Now the dissolution has failed to happen in the midline. Yes? So in the midline, the dissolution of the septum has not happened. Who is going to tell me why it was important to know that the dissolution direction is caudal to cranial? Tell me. So from this part, the septum has dissolved. So it started dissolving from the bottom. So some part of the septum has dissolved, but some part of the midline septum is still remaining. Yes? So some part of the septum is still remaining. Now you understand why certain one-liners which irritate you, hame nahi pasand aate. We hate examiners who ask us one-liners, and we ask them, how will you become a doctor by knowing this? This is exactly how you will use every single information in your notes copy clinically. Everything, believe me, that goes into your copy, you will use it clinically sometime or later in your life. Okay, so in the bottom part, the septum has dissolved and the septum is only in the upper part, which means if I draw two drawings, A and B, which is the correct septate uterus? Which is the correct septate uterus? Tell me, A or B, right? So please never ever draw septate uterus like image B. The septate uterus doesn't start from below and hang in the center. You will have to draw it from the fundus coming downwards. The length of the septum can be variable. Okay, the length of the septum can be variable. Okay, so it is the A which is the correct form of septate uterus. Okay. Very good, you've all understood this. Now look at the gross image. Now what I have done is, I have shown the same uterus, but I have cut open the cavity of the uterus. Yes, I have cut it open. And when I cut it open, the same thing is what you see. So the external contour of this uterus was normal, right? So the fundus is normal, but we are seeing two cavities. And in between the two cavities, this septum is hanging from the fundus, right? So in between the two cavities, the septum is hanging from the fundus. So this type of a Mullerian anomaly is called as septate uterus. Okay, this is what is called as septate uterus. Very good. Now, look at the picture that I'm going to show you now. In this picture as well, there are two cavities. right? And in between the two cavities, you are again seeing a barrier. Okay. Now tell me the correct answer. This barrier, where will you look at it to know the correct answer? Will you start looking at it from the outside? Or will you first go inside of the uterus to see whether there is a barrier or not? What do you want to see first? What do you want to see first? Do you want to see from the outside? Or do you first want to go inside the uterus and see whether there is a barrier or not? So, if you start from the inside first, do you realize so if I see from the inside, do you realize that both of them will appear same? Yes. If you look at from the inside, both of them will appear the same. There are going to be two cavities in this uterus, and there are going to be two cavities in this uterus. But only one of them is septate. Which of these is septate? The one septate is the one which have the normal fundus, right? Whereas the one with two cavities, okay, but the fundus is dipping, is bicornuate. Okay, so please remember this, very, very important. You cannot start looking from inside, because if you look from inside, both of them will look the same and you will do blunders. To identify what it is, you have to look at the outside of the uterus. Two cavities and a normal fundus is what is septate. Two cavities and a dipping fundus is what is bicornuate. Now do you understand why did I teach you that fusion begins or goes caudal to cranial? Can you tell me what has happened in the bicornuate uterus? What has happened in the bicornuate uterus? Let's see who can tell me what has happened in the bicornuate uterus. The two Mullerian ducts started to fuse, and that is why there is one cervix. Okay, so the two Mullerian ducts started to fuse. That is why there is one cervix. They did fuse in the lower part of the uterus as well. But when you go above, the fusion stopped. Yes, the fusion stopped. That is why that silly one-liner, caudal to cranial, I taught you, you did not like, ma'am, why do I have to mug up? This is why you have to know. Okay, so yes, these are different kinds of fusion defects, right? So these are different kinds of fusion defects. So now once you understand what is a bicornuate, remember the complete name for bicornuate is bicornuate unicollis. Okay, bicornuate means two cornus or two uterine horns. Okay, uni means one, collis means cervix. So bicornuate unicollis. Okay, this is why I have also shown you the gross image. Do you see the gross image now? Okay, the fundus is dipping, right? So this cannot be septate. The outer surface is what? The outer surface is abnormal. So this is a bicornuate uterus. So do not ever make a mistake. Whenever you get a question, a visual MCQ in the exam, and we are asking you what is it, you have to answer first looking at the external contour. Then you comment on the cavity, and then you go on the nomenclature. Now, I am going to show you one more picture, and you will now tell me yourself what is the problem. Okay, so now I am showing you one more picture. Collis is cervix, unicollis. So two uterine horns and one cervix, bicornuate, unicollis. Okay, now this picture, if you see, the external contour is definitely abnormal, right? So the external contour is abnormal. There are two uterus. Very interesting. There are two cervix as well. Which means what has happened? What has happened? Complete lack of fusion. Okay? Complete lack of fusion. Okay? So when there is a complete lack of fusion, two separate uterus have formed. Okay? Two separate uteri have formed. Right? One Mullerian duct has formed one uterus. The other Mullerian duct has formed the other uterus. And each uterus has its own cervix, right? So each uterus has its own cervix. This is complete lack of fusion. Okay, this is complete lack of fusion of the Mullerian ducts, and this is called as uterus didelpheus. Okay, this is a uterus didelpheus. There are two fusion. There is complete lack of fusion. So please understand, when there is a complete lack of fusion, it is a uterus didelpheus. And no, this is not called as biconuvate bicollis. Okay, this is called as uterus didelpheus. Remember the word. Yes. So now remember the correct definition of uterus didelpheus. Okay, the uterus didelpheus will have two uteri. It will have two cervices, but one vagina. That is the core definition of uterus didelpheus. Okay, two uterus, two cervix, and one vagina. Okay. बाइकॉर्नुवेट में सिर्फ दो हॉर्न्स थे, ओके, वो भी ऊपर की तरफ, नीचे इट वाज अ फ्यूज्ड यूटरस. सो देयर वर टू सेपरेट कैविटीज, राइट, विद अ सिंगल cervix, that is unicollis. All right, this is didelpheus. Now listen to me carefully. Sometimes there may be complete septum between the vagina as well. Okay, so sometimes in uterus didelpheus, okay, so sometimes in uterus didelpheus there will be two uterus, each with its own cervix and each with its own vagina. Please remember, presence of two vagina is not mandatory for didelpheus. The core definition is two uterus, two cervix, and one vagina. Sometimes, yes, you will also see two vaginas. This is only sometimes, not always. So presence of double vagina is not a requirement to make a diagnosis of uterus didelpheus. Okay, it may be seen, but it is not a requirement. Okay, biconuvate bicollis में कहीं ना कहीं नीचे फ्यूजन जरूर होगा. Here there are two separate uteri. All right, don't go with biconuvate bicollis ever. Okay, you don't have to answer that. Why? Let's look at this now. So out of the three Mullerian anomalies that I have shown you, which is the most common Mullerian anomaly? So the most common Mullerian anomaly is septate uterus. Okay, this is in general the most common Mullerian anomaly. The second most common Mullerian anomaly is bicornuvate unicollis. And not only these two are the most common ones, they are also differential diagnosis of each other. Okay, they are also the differential diagnosis of each other, right? So these are the reasons why you need to know them. Now let us see another thing which is very important with these Mullerian anomalies. If a woman has these Mullerian anomalies, let's say septate uterus or biconjugate or didelphius, what are the problems that these women are going to have? What are the problems that they are going to have? So, no, if there are two vagina, you still call it as didelphius. It's an additional finding in didelphius and is often asked as a question. Okay, which anomaly of the Mullerian ducts is associated with a longitudinal vaginal septum, right? So, very often they will ask you which Mullerian anomaly is associated with a longitudinal vaginal septum. The answer is didelphius. It's a common finding, but it is not a requirement. Now, let us look at few important things. When you talk about septate uterus, and we said there is a septum coming from the fundus, you have to know that this septum, okay, this septum is poorly vascularized. Right? So this septum is poorly vascularized. So can you tell me what will happen if a conceptus comes and implants on the septum? Let us say a conceptus comes and it implants on the septum. Will this conceptus be able to undergo further implantation? Will it be able to undergo further implantation? No. So this conceptus will be aborted. So please remember, the most common Mullerian anomaly to be associated with abortions is going to be septate uterus. Why? Because it is the most common. So obviously it is also the one which is most commonly associated with abortions, right? So septate uterus can cause abortions, even recurrent abortions. Recurrent matlab bar. She gets pregnant once, it will abort, again, it will again abort, and so on, right? So septate uterus is most commonly associated with abortions as well as recurrent abortions. Okay, now, generally, the other problems that these Mullerian anomalies can cause are preterm labor. So apart from abortions, right, they can also cause preterm labor, which means now your doubt will be, ma'am, can biconjugate cause abortions? Yes. So even a biconjugate uterus can cause abortions. But the one most commonly associated with abortions will be septate, right? So all Mullerian anomalies can cause certain problems in pregnancy. These could be abortions, that is the first one. They can also cause preterm labor. Why? Because the cavity size is small, okay? So the cavity size is small. Please remember, uterus has a natural tendency. If you put something in its cavity, it is going to contract and expel it out. So if the cavity is even smaller, it is likely to do that. Okay. So preterm labor, it can also cause IUGR. Again, for the same reason, intrauterine growth restriction, because of less space available to the baby, right? So it can cause abortions, preterm labor, IUGR, as well as malpresentations, because the space is less. So if you realize all the problems that are occurring in Mullerian anomalies is because of less space, right? So these could be abortions, these could be preterm labor, it could be IUGR, it could be malpresentations. All Mullerian anomalies can call all of these, but the one which is most commonly associated, as I said, with abortions is going to be septate uterus, right? It is going to be septate uterus. Okay. Now, biconjugate, as I said, is the second most common Mullerian anomaly, and I said it is a DD for septate. Why? Because if you look from inside, both septate and bicornuate look the same, right? So from inside, they actually look the same. There are going to be two cavities, and separating the two cavities, you see a structure, right? Only if you look at the fundus, you will be able to tell which one is septate and which one is bicornuate. Okay? Can bicornuate uterus cause abortions, preterm labor, IUGR, malpresentations? Yes, it can also do all the problems. But generally speaking, okay, generally speaking, bicornuate uterus has good reproductive outcome. So generally, it is not going to cause many problems. So usually the outcome of pregnancy is good, okay? But yes, it can cause abortions, preterm labor, IUGR, malpresentations, because again, the space is less, okay? Similarly, as far as didelphius is concerned, okay, so as far as didelphius is concerned, it is also associated with good outcome. Yes, it can cause abortions, preterm labor, IUGR, malpresentations, but generally has a good outcome, right? So in other words, if I ask you which Mullerian anomaly has worst reproductive outcome, what will be the answer? Which Mullerian anomaly will have the worst reproductive outcome? It will be again septate uterus. So septate uterus is not just the one that is most common. It is also the one that has worst reproductive outcome, which means the poor lady will come to you with repeated abortions or problems with her pregnancy. So in other words, if you come across septate uterus in a patient, okay, of recurrent abortions, do you need to treat her? Yes or no? The answer is yes, right? Yes. On the other hand, if I ask you, do you usually need to surgically treat bicornuate or didelphius? The answer is no. So because they have good outcomes, the bicornuate and the didelphius usually do not need surgical correction. Okay, so they generally do not need surgical correction. In some cases they may need, but generally do not need surgical correction. Whereas septate uterus is the one which will need surgical correction. Yes, it will need surgical correction. Now, once you know what is a septate uterus, I have shown it to you, I have drawn it for you. Can you tell me what, in your own language, what surgical correction would you want to do? Tell me, what surgical correction do you want to do? So the answer is, in simple language, remove the septum. It is this septum which is creating the problem. So in simple language, we will say you remove the septum. So now you will answer me, which way do you want to remove the septum? Do you want to come from outside? That is option number A. Go from the fundus, reach the septum, remove the septum and then close the fundus. Or do you want to go from the bottom into the cavity and then remove the septum? So which of the two would you want to do? Do you want to go from top, open up the uterus, reach the septum and remove the septum? Or do you want to go from bottom and remove the septum? Which one would you want to do? If you were the clinician in place of me, what would you do? Tell me. Kya karoge? Okay, so I see most of you are saying that we will go from the inside. Anybody can give me a good reason why? Why? Why do you want to go from the inside and not go from the top? Because there is a natural opening here. Yes, The cervix has an opening. We can go through the external os, into the cervical canal, into the internal os, reach the uterine cavity, and then I will cut the septum. This is called as transcervical septum resection. Right? Why would we want to go from outside where I have to cut the entire uterus, which can actually make the wall of the uterus weak? Yes. So if I go from the top, this will make the uterus weak. Why do that? When I have a natural opening through which I can go and then operate inside. Okay. Now, so this is called as transcervical septum resection. But what am I going to put through the cervix? I have to put some instruments. Yes. So this procedure where we put a scope se dikhega, and scope has two channels. One channel through which I can see, another channel through which I can operate. So this scope, endoscope, whenever you go inside a cavity, you call it as endoscopy. Yes. So this endoscopy which we do for uterus is called as what? Hysteroscopy. Right? So the endoscopy that we do is called as hystero. Hystero means uterus. So we'll do a hysteroscopy. So the other name for transcervical septum resection is hysteroscopic resection of the septum. Right? So hysteroscopic resection of the septum. This is the treatment of choice for septate uterus nowadays. Right? So this is the treatment of choice for septate uterus nowadays. Whenever you want to operate, this is what I'm going to do. In older times, when there was no hysteroscopy, right? Then we used to go from option A. We used to cut open the uterus. We used to go inside the cavity, repair, and then close. But now we have switched to hysteroscopic procedures. So the older surgeries are called as Tompkins surgery and Jones surgery. Okay. So these are older surgeries for septate uterus. They are not done in modern times. In modern times, we will do hysteroscopic resection or transcervical resection. Okay. Now, so this is what we will do for septate uterus. Usually, okay, I said bicornuate and didelphius. Do they have a good outcome or bad outcome? Usually they have a good outcome. In case you want to operate on them, let's say this woman is repeatedly having preterm labor, right? So let's say she is repeatedly having preterm labor. She has either bicornuate or didelphius uterus. What would you want to do for her? Now let's say we do want to treat her. So usually they do not need surgical correction. But if we have to do surgical correction, which will be usually for recurrent preterm labor, right? So if they have recurrent preterm labor, I want to operate on them. Can you tell me in your own language, okay? Can you tell me in your own language, what surgery do you think you want to do? Both of them look like this. So this is bicornuate and this is didelphius, right? I told you in both these uterus, right, what is the problem? The problem was because of less space. Yes, so these cavities are small in size. Can you tell me in your own language, how will you increase the size of the cavity? How will you increase the size of the cavity? Yes, very good. So your own language is, you will join the two cavities simply. So join them and make a big one. Very good. So this procedure where we might have to operate for bicornuate or didelphius, right, is called as metroplasty, okay, which is a procedure of joining the two. And the person who gave it was called as Strassman. So the surgery is called as Strassman metroplasty. Okay, so we are going to, yes, join the two and give a bigger cavity. This is a procedure which is called as metroplasty, named after the surgeon who gave it. So we call it as a Strassman metroplasty. MCQ. All the following are surgeries for septate uterus except A. Jones, B. Tompkins, C. Transcervical surgery, and D. Strassman surgery. So the MCQ is, all the following are surgeries for septate uterus except, what is the answer? What is the answer? So the answer will be Strassman. Strassman is not a surgical procedure for septate uterus. It is a procedure which we do for bicornuate or didelphius. Okay, so it is a procedure that we do for them. Right? Now, since we have talked about treatment of choice for septate uterus being transcervical resection, okay, I want you to now look at something. Okay, I'm going to show you a little video clip, right, where I will show you how we do the hysteroscopic resection of the septum. So this is the two cavities that you are seeing on the inside. Okay, so this is one cavity, this is the other cavity, and there is a thick septum between the two. And this is a hysteroscopic septal resection that we are doing. So we will simply cut the septum, and that is going to be the treatment. And you could see there was hardly any bleeding from the septum. Yes, and that's what I told you, that it is a relatively avascular septum, right? It is made up of fibrotic tissue, right? So we simply cut it out, and this is what is a transcervical resection, right? So you see the two cavities and you simply cut the septum between the two, okay? Now, coming to a very important thing that you have to know. Please remember, if you suspect a Mullerian anomaly, now come to real clinics. Okay, the real clinics go like this. A woman comes to you with 3 recurrent abortions, and you are suspecting Mullerian anomaly, right? Please remember, a patient will not come and tell you that, doctor, I have septate uterus, please treat me. Okay, you have to know how they can present. So let us say a woman comes to our clinic, right, and she says that, you know, she's been having 3 recurrent abortions, and when you hear about it, you think, oh, this could be a Mullerian anomaly, right? Now comes the question. You know everything about Mullerian anomalies. They could be septate, bicornuate. You think it is more likely going to be septate. So now you are suspecting a Mullerian anomaly. Can you tell me, in this patient, what is going to be the first investigation that you would like to advise? Keep your basic concepts in mind when answering this. Remember whatever I have told you. I told you how to identify this. So now tell me the first investigation that you would want to advise if you are suspecting a Mullerian anomaly. What are we advising? So the first investigation always should be a routine ultrasound. Why always? it is easily available, there is no radiation exposure, gives idea about gross anatomy, right? So this is the reason why the routine ultrasound is going to be first investigation. And what do you mean when I say routine ultrasound? You know, those ultrasounds that are readily available, you know, in your hospitals and everywhere around in the clinics or small labs, okay? These are all 2D ultrasounds, okay? They are two-dimensional ultrasound machines. So all routine ultrasound machines are 2D machines, okay? The problem with this is that this can give you some idea about whether a Mullerian anomaly is present or absent, as it can give you a gross anatomy. But it cannot identify which exact anomaly is this, because it does not give us a good 3D view of the anatomy of the uterus, right? So although it gives us a fair idea whether the anomaly is present or not, it is not able to tell us exactly which one is it, okay? So your first investigation is ultrasound. It will tell you whether she has an anomaly or she doesn't have an anomaly. Now, let us say she does have an anomaly, but now as a doctor, I'm interested in knowing which anomaly it is. Now, can you tell me what is the most important thing to look at if you want to comment on which anomaly it is? I told you, if you want to know which anomaly it is, what area do you want to look at? Batao, we want to look at the fundus. You remember I said always first look at the outer contour, not the inside, okay? So the investigations which will help us give us a good view of the fundus and the 3D anatomy would be a 3D or a 4D scan. So these days we have 3D and 4D ultrasound machines available, right? So once you know that the anomaly is present and I want to know which one it is, then it will be a 3D scan. So a routine ultrasound is the first investigation, but when they ask you the investigation of choice, it will be a 3D ultrasound. So once a routine ultrasound says that yes, there is an anomaly present, it could be septate, it could be biconjugate. So they say query septate, query biconjugate, right? Now what do? I order a 3D ultrasound, okay? Usually the 3D ultrasounds are good enough. They give beautiful pictures and you will finally get the answer whether it is septate or it is biconjugate, okay? In case the doubt remains, usually it will not remain, but in case if you still have a doubt, okay, the 3D ultrasound was not very able to give you the answer, then if the doubt remains, then I will go for the next investigation, which is MRI. MRI is the gold standard investigation. It is non-invasive, right? So it is a gold standard investigation, non-invasive, but it is much more expensive than ultrasounds, right? So it is much more expensive than ultrasounds, okay? Now, let us come on to some of your queries that you have. Some of you don't put your brain when you answer queries. You will just answer queries because you want to ask them. Some of you are asking, why not hysteroscopy? So who is going to tell me? Hysteroscopy shows you the uterus from where? Outside or inside? Come on, tell me. Will it show you the uterus from outside or inside? It is going to show you the uterus from inside. Now suppose I am going to do a hysteroscopy in these two, okay? Query, I don't know what anomaly it is, and I am doing hysteroscopy. I go inside the first one and I see there is a septum hanging. I cut it. I was lucky, it was septate. I do a hysteroscopy in the other one. I go inside. I see a septum hanging. I cut it. आउच आउच, क्या हो गया, कहाँ घुस गए, एब्डोमेन, पूरा यूट्रस खोल के आप एब्डोमेन में घुस गए, राइट? सो हिस्ट्रोस्कोपी अलोन cannot differentiate. Hysteroscopy is reserved for the treatment of septate uterus. Once you have confirmed it is separate, then I'm going to go and cut it out. If you do this cutting in bicornuate, तो पता है ना क्या होगी, पिटाई, ouch, patient की relative पिटाई करेंगे. Okay, so remember, do not answer hysteroscopy as the investigation of choice. We use it for treatment. The second reason we never use hysteroscopy as investigation of choice. Why? It is invasive. Okay, it is invasive. Why do you want to do such an invasive procedure, giving her anesthesia, right, when you can do the same thing non-invasively? Yes, खुद को डाल के देखो. अगर मैं तुम्हें एक ऑप्शन दूं, एक प्रोसीजर है जो मैं अल्ट्रासाउंड से पता कर सकती हूँ और एक है जो मैं हिस्ट्रोस्कोपी से पता कर सकती हूँ. What would you ask me to do? Ma'am, do hysteroscopy, it looks more fancy, right? So we don't do fancy things. We do what is required. We do what is as per the protocols. Okay? Another person was asking me, ma'am, why not HSG? I haven't taught you HSG as of now, but in HSG we do the same thing. Through an instrument, we put a dye inside and then take X-rays. Okay? So number one, radiation exposure. Number two, it will again show only the inside. So on HSG, on hysteroscopy, the bicornuate and the septate will look the same. They will look the same. They will not, you will not be able to differentiate, because these two procedures will show you the uterus from inside and we will have an ouch moment. Okay, so we don't want any ouch moments. Okay, you are surgeons. Surgeons are, they know what they're doing. So no ouch for us. Okay, so remember these are very important. Whenever you suspect a Mullerian anomaly, the first investigation is ultrasound, which is a routine 2D scan. If you have picked up an anomaly and you want to know which one it is, okay, it is going to be a 3D ultrasound, right? And if you still have doubts, you go in for gold standard, okay, which is going to be MRI, right? So this is what we are going to answer when we get to investigations. Now, a very, very important thing, and let me see if you understood well or not. Do Mullerian anomalies, okay, do Mullerian anomalies cause infertility? Do Mullerian anomalies cause infertility? What is the answer? Go with concepts, no mugging up. मेरी क्लास में सिर्फ दिमाग लगाना है और वो बेसिक से लगाना है. So come on, tell me. Right? So please remember, I said whatever problems the Mullerian anomalies do, they do because of less space. Okay, sperm to fertilize the ovum or to reach the ovum doesn't need much space. It needs motility, which it has. Okay, so generally, please remember, Mullerian anomalies will not cause infertility. Okay, so generally, they don't cause infertility. But whenever we go for exams and we have to show you a picture, I will say, a patient was being evaluated for infertility and has the following image. Which Mullerian anomaly is this? ऐसा क्वेश्चन क्यों बना फिर? ये है तुम्हारा ouch moment. Surgeons का ouch moment होता है when we do something wrong, right? Your ouch moment is when you have read something with us, but you are asked something else in the MCQ. Okay? So ये तुम्हारा ouch moment है. अब the first thing you do is say XYZ to ma'am. Madam is blah. Okay, beep, 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 beep. Then you start putting your brain. So your first thing, madam ने तो पढ़ाया था infertility नहीं होता है. Why are they asking us this question? Tell me. So most of the times, Mullerian anomalies are incidental findings. When you are evaluating women for other things. Okay, remember this. Okay, so most of the time, Mullerian anomalies are incidental findings, right? You were evaluating the woman when you found out she has a Mullerian anomaly. Okay, answer the next level MCQ. Next level MCQ. Your patient was being evaluated for infertility, and on evaluation she has a bicornuate uterus. Which of the following would you advise her? Okay, A, Jones procedure, B, Strassman procedure, C, Tompkins procedure, D, no procedure to be done. Tell me. Your patient for infertility was being evaluated and she has a biconnuate uterus. Okay, what do you want to do? No operative procedure. Remember what I told you. Bicornuate uterus usually has good reproductive outcome, right? Good reproductive outcome. So no operative procedure required. I will twist the question again for you. Which is the most common Mullerian anomaly to be associated with infertility? Let me see who are the bright ones. Which is the most common Mullerian anomaly to be associated with infertility? Anyone? Come on, jaldi batao. So, septate, bicornuate, unicornuate. What is the answer? The answer is septate. Why? Because it is the most common anomaly. So since these anomalies are incidental findings, obviously you will find the one which is most common, right? Which is going to be septate uterus. None is not going to be in the options, bache. Okay, we are asked, the question is antegrade. Which Mullerian anomaly is most commonly associated with infertility? The answer will remain as septate because it is the most common, and if at all it is an incidental finding, it will be this one. Is it clear to all of you? Okay, now I want you to look at one more picture. Okay. Before we will take a break, we will see one more picture, and it is going to be this one. So I have already described this picture half for you, that the picture has a normal external contour or a normal fundus. But who is going to tell me what is the finding here? What is the finding here? So if you look at the finding, on the inside, there is a small projection from the fundus. Yes, on the inside, there is a small projection from the fundus. This is not septate. Septum has to be at least some big to say that it is septum. So this is not a septum. This small projection from the fundus is called as arcuate uterus. Okay. This small projection from the fundus is a arcuate uterus. All right. It is not an anomaly. It is a normal variant. So it is a normal variant. So will it cause any problems if I want to ask you? No. Arcuate uterus does not cause any problems. Okay. Arcuate uterus does not cause any problem. Okay, so this is not septate. A small dip, a normal contour is what is arcuate uterus. Okay, right? Fine. Now, please remember this thing. I'm going to give you in the end of Mullerian anomalies, I'm going to give you a classification that might be asked in the exams. It is called as ASRM classification. It is the American Society of Reproductive Medicine, right? So it is the American Society of Reproductive Medicine, right? And this has given one classification of Mullerian anomalies. Let's see what that classification is. So here, type 1 anomaly is a Mullerian agenesis, where the Mullerian ducts do not develop at all. Okay, so Mullerian agenesis, right? This is type 1. In the category of type 2 comes unicornuate. A unicornuate uterus is when one Mullerian duct develops into the uterus, but other one remains rudimentary. So one Mullerian duct has developed into a uterus, but the other one is rudimentary. Okay, this is a unicornuate uterus. There are just 2-3 things that you should know about unicornuate uterus as one-liners. They have some clinical relevance, and that is why I'm telling you. Unicornuate uterus is the Mullerian anomaly which can be associated with ectopic ovary. That's number one. Because when you will do the ultrasound in these women, you may find this. So you have to know that yes, it may be associated with ectopic ovary. Second, unicornuate uterus, sometimes what happens is that this rudimentary uterus has developed, but it is really, really small. So there will be an endometrium inside. And the endometrium is monthly going to bleed. Sometimes what happens is that this rudimentary horn is blocked. It has no connection with the main horn, right? So the rudimentary horn is blocked and it has no connection with the main horn. So what will happen to all the blood? It will keep collecting in this rudimentary horn and it will cause a lot of pain. So this is a kind of Mullerian anomaly that can cause unilateral dysmenorrhea. When I go on to dysmenorrhea, which is painful menses, I will teach you how usually normal dysmenorrhea is midline. It's never towards one side. But in a unicornuate uterus, the pain will be localized to one side, right? So, American Society of Reproductive Medicine, I spoke it out, but I did not write it down. Okay. So, it can cause unilateral dysmenorrhea. Sometimes a pregnancy can get implanted here in the rudimentary horn, right? So, it can also cause ectopic pregnancies. So, these are the things that you should know about unicornuate uterus associated with ectopic ovary, unilateral dysmenorrhea, and ectopic pregnancy, right? So, this is type 2 or unicornuate uterus. Ectopic matlab at a different site, beta. That's what is the meaning of ectopic. Not at the normal site, but the ovary is present at a different site. Okay. Type 3 Mullerian anomaly is uterine didelphius. Okay, uterine didelphius. Type 4 is bicornuate. Beta, for you people, whenever MCQs, exams or anything talks about bicornuate, you have to consider it as unicollis. For you, you have to remember bicollis doesn't exist. It's a super rare thing. Do not think about rare things. They will give you rare marks. Okay. So whenever we talk about bicornuate, it is always meant unicollis for you people as far as any exams are concerned. Okay. Type 5. Type 5 is septate uterus. Okay, type 5 is septate uterus. And type 6. Okay, so type 6, if you talk about it, these are the kind of Mullerian anomalies that are happening because of exposure to diethylstilbestrol in utero. So DES is a teratogen. Okay, diethylstilbestrol is a teratogen. Okay, if it is given to a pregnant female, it will cause certain problems in the fetus, and it definitely causes problems in the uterus of the fetus if it's a female baby. The typical findings with DES exposure are a T-shaped uterine cavity. MCQ. Okay, bache, this is a T-shaped uterine cavity. All right, so T-shaped uterine cavity is what is due to exposure to diethyl stilbestrol, right? So this is the ASRM classification that you should know. Less likely to be asked, but in case they know, just know this much. Don't go into any more details, okay? Right, so these are things that you should know about different kinds of Mullerian anomalies and things that we ask you. Also, super important is one thing. I told you, Mullerian ducts are also called as what ducts? Paramesonephric ducts. Yes, you remember, they are also called as paramesonephric. Now, can you tell me, urinary tract developed from what embryonic structure? Mesonephros, right? So the urinary tract is going to develop from mesonephros. So you have seen how mesonephros and paramesonephros are closely associated. So if there is a problem in the development of paramesonephric ducts, usually this patient will have a high risk of urinary tract anomalies. Very important. So any female who has Mullerian anomalies has a very high risk of urinary tract anomalies as well, which means all females or any female with Mullerian anomaly must be investigated. Okay, so she must be investigated for urinary tract anomalies. So you must get a ultrasound KUB done, and if required, a IVP done, right? So you need to get ultrasound KUB or IVP, but what you need to know is that you have to investigate her for urinary tract anomalies as well. So all females who have Mullerian anomalies must be investigated for urinary tract anomalies. Beta ji, what does teratogen mean? Teratogen, mother ko kuch nahi karta bache. Teratogen is a substance which, when given to a pregnant woman, will cause problems in the baby. So when I say diethylstilbestrol is a teratogen, it doesn't do anything to the mother. Okay, bache? It will cause all problems in the fetus. And if the fetus is a female, then the classic anomaly is what? It is a T-shaped uterine cavity. Okay, it is a T-shaped uterine cavity. Now, please understand, diethylstilbestrol causes one more characteristic thing which is required for exams. Okay, so one I told you is T-shaped uterine cavity. The second, it can cause clear cell cancer of vagina, very often asked as an MCQ. So clear cell cancer of vagina. Third, if the baby is a male baby, it is classically associated with hypospadias. Okay, it is classically associated with hypospadias. Listen to me very carefully. ये सब MCQ हैं. If it is a female fetus, DES does not cause renal anomalies. But if it is a male baby, DES will also cause renal anomalies. So these are some of the important points that we do tend to ask about diethylstilbestrol. Okay, so T-shaped cavity, right? Clear cell cancer of vagina. In the male baby, hypospadias and renal anomalies. Renal anomalies are not seen with female fetus, right? So this is what you should know about normal development of the uterus and abnormal development of the uterus. We'll take a short break, okay? We will take a 15-minute break and we will resume the class from here, okay? अरे भाई पारस बेटा जी अभी तो सिखाया हाइपोस्पेडियाज मदर में थोड़ी हो जाएगा hypospadias is abnormal urethral opening in a male. It cannot happen in a female. Okay, so we said teratogen is not going to affect a male, the mother. Teratogen is going to affect the fetus. So ये सारी चीजें fetus में हो रही हैं. Okay, so you will get these things, you will see these things either at birth or when the child grows up. Okay, chalo, we will take a break and we'll come back after 15 minutes. Let's ensure we do not have many ouch moments in the exam. So you will have to keep revising with me, keep learning concepts and learn the application, which is what is most important. Okay, chalo, milte hain.